All right, hi guys. Sorry for the technical difficulties, and welcome back to Psychiatry Network's Journal Club. I am just waiting for Dr. Nicole Garber to join us, and we had tried on another video. It wasn't quite working. Something was going on with the audio, but I am, hey. It's nice to see some of you guys like every week. I'm noticing some of the same names, week after week. So I can see who's dedicated to their learning and their CME. So welcome. I'm just waiting for Dr. Garber just to get back on. All right. Let me see if I can just invite her. Oh, there we go. So, yeah, we did try this. Oh, okay, there she is. Hi. Do you want to take out your earbuds? Maybe I'm not. Hello? Hi. I'm not hearing anything. Do you want to take out your earbuds? Okay, let's see if that helps.
Can you hear me now?
I think, is it frozen? Oh, wow, now I can hear you. Yeah, it looked like it was frozen or something. Okay. Oh, there it is. Okay. Are you okay? For some reason, our audio is not working the way it normally does. Carrie, I think Carrie Janik is asking if the board questions for each article have been released yet. I am honestly not sure. I don't believe that they have. I think we are waiting till the end of the month for the ABPN to send them out. Okay. Hello?
Yes, can you
Hey,
hear me?
Nicole, can you hear me?
I can hear
Oh,
you. Can you
yeah.
hear
For
me?
some reason now it's working. Yes,
Awesome.
we can hear each other. Okay, sorry guys for that. Sometimes, I don't know, Facebook is really like tricky, I think, sometimes with the way these videos work. So I'm just glad that we can get on today. So welcome. Thanks for joining us, Dr. Garber. And I mentioned in the first video that we're talking about binge eating disorder today, but that's what we're talking about. And let me just introduce Dr. Garber. So Nicole Garber, MD, completed her general psychiatric residency at Emory School of Medicine and her child and adolescent psychiatry fellowship at Baylor College of Medicine. She's double board certified. In addition, she's completed advanced trainings in dialectical behavioral therapy, or DBT, psychodynamic therapy, mentalization-based therapy, and acceptance commitment therapy. She's currently the chief of psychiatry at the Meadows Ranch. In addition to providing psychiatric care, she also runs 2 DBT groups weekly. She's been a member of the Psychiatry Network for about a year and enjoys learning through the complex cases and resulting discussions. So with that, I will let you take it away.
Great. Thank you guys so much. So we're going to be talking about binge eating disorder, which formally became a DSM-5 diagnosis in 2013. Before that, it was a research criteria. And interestingly, this is the eating disorder that actually has the highest prevalence rate, about 3% of the population criteria for binge eating disorder. Still a higher percentages of females compared to males. And the bare minimum criteria is at least one binge per week that has been going on for at least 3 months with the resulting distress. Because some people would binge all day, they decided to put a discrete period of time to it, and that period of time is 2 hours at this point. And then there's the psychological components of feeling out of control, feeling shame, eating past hunger cues. So with this, there's obviously a lot of comorbidities, just like any other eating disorder. For this one, the highest comorbidity in terms of mental health is depression. And then along with that, because a lot of these people actually become obese, the physical components and complications can be metabolic syndrome, which can lead to a whole bunch of other problems. The other piece of it is that this is a reason, binge eating disorder is a reason that some people fail bariatric surgery. Either they can't get the bariatric surgery because they don't meet criteria in terms of impulse control, or they get the binge or get the bariatric surgeon and then they actually kind of eat past that point of it and undo the results. Obviously, binge eating disorder is a psychological and physical problem, and so treatment studies have been looking at how to best manage that. And this article looked at, did a meta-analysis to look at treatment modalities that would help. And they did this because there's some consensus among the guidelines. So APA and the NICE guidelines both recommend CBT and serotonin reuptake inhibitors, but kind of who gives the treatment is a little bit different versus clinician given or self-directed. So they really were looking for kind of the gold standard treatments. So they did a meta-analysis, and they were looking for studies that were randomized controlled studies that had at least 10 participants. From this, they went through 34 studies, 9 that had comparisons to wait lists, and then 25 that actually had comparisons to placebos. At the very end of it, they actually ended up using 16 trials to look at the outcomes of the study. There were a whole bunch of different things that they did look at, including medications, DBT, psychodynamic therapy, and then behavioral weight loss. What this article eventually focused on was a combination between cognitive behavioral therapy and medication assisted treatment. So they looked at a total of over 1,000 patients doing all of these different treatments. And the first one they looked at were the core components of binge eating. And they looked at, can we get somebody to abstinence so they're no longer binging? Or can we at least get them down to a reduction of the number of episodes that they're binging per week or per month? So looking at that, what they found is that therapist-led CBT, looking at that compared to waitlist, significantly more people met abstinence with the active treatment of the therapist-led intervention compared to waitlist. The same was true for the dexamphetamine group versus placebo. And there was a higher number of abstinence with the second generation antidepressants, and particularly they were looking at medications like bupropion, Cymbalta, escitalopram, fluvoxamine, and sertraline. When they looked at, can we get a decrease in the number of binging episodes, so response, not remission, they found that in addition to the lisdexamfetamine and the therapist-led CBT, topiramate also decreased the number of episodes per week, and so did the second-generation antidepressants. So again, for abstinence CBT, that was therapist-led, and the lisdexamfetamine were the ones that helped the most for abstinence. And then with decreasing frequency, you can also add in the topiramate and the second generation antidepressant. They also looked at eating-related psychological components, and that was really more the obsessions and kind of compulsions around that. Again, the lisdexamfetamine was found to help significantly decrease the obsessions and compulsions, which is the theory of the mechanism of action for binge eating. Is it's not the decreased appetite they're saying it's helping with the obsessions, the compulsions, and adding a level of increased impulse control. Along with that, topiramate also was found to be helpful with the obsessions and compulsions, as was therapist-led and self-guided CBT. In addition, the therapist and self-guided CBT helped with noticing hunger cues and cognitive controls over eating, and to help with the body image controls, with the amount that they put on the evaluation of eating, shape, and weight. They also looked at the comorbid outcomes in terms of the mental health outcomes, particularly looking at depression. And out of that one, what they found was that the antidepressants significantly decreased numbers on the Hamilton Depression Scale. Was the only one that really was that they looked at that was significant. The CBT in terms of both the therapist and the self-directed were not significant. Again, probably because the actual CBT structure and homework was more going along with the binge eating and the cognitive distortions around that instead of specifically trying to target the depression. And then finally, they looked at weight-related outcomes. Within the work that I do at inpatient and residential, we really don't focus on weight loss at all. We really focus on decreasing the behaviors, because at that level of care, usually initially we don't see significant weight loss. It's usually after they've been binge-free for some period of time that we begin to really focus on that. So what they found was that the interventions that they found helpful for decreasing both BMI and for decreasing weight were the two medications. So topiramate and the lisdexamfetamine were helpful. Along with that, looking at components of metabolic syndrome, the only thing that was significant was the lisdexamfetamine reduced the number of triglycerides compared to placebos. They also looked at medication side effects and side effects in general. As would be expected with a stimulant medication, there was a decrease in appetite. With that, again, the manufacturers of the medication and the approval that they got said that this was not the mechanism of action. They also found that there was an increase in arousal with the topiramate and the fluvoxamine, and then things that we would typically see, which were sleep disturbances and some GI complications. With that, medications were very rarely discontinued because of side effects. So it was interesting that what they noted in the discussion piece of it was that binge eating disorder isn't usually just binging. There's usually the cycle of restricting for some period of time and then kind of binging later on. So people with binge eating disorder often have deficits in their awareness of their hunger cues and also their fullness cues. And what they found was that doing some of the CBT work was actually more helpful for that than doing medications. Again, comparatively, it looks like the therapist-led CBT was more helpful than self-directed CBT. And my guess is part of that is just when people get stuck, the therapist-led can kind of help unstick them and give them a couple of additional pointers or things that they may not have thought about on their own. Their hope was to increase kind of the compliance and how we all treat binge eating disorder, to begin to standardize the treatment across different treatment centers and across the different states and countries within that. And obviously we need to continue doing more research on that. And I see a couple of questions have come up. So can lisdexamfetamine be used in a patient who has a history of seizures? It can. We would need to look at why they had that seizure, and always I'm incredibly conservative with medications, and if they have an ongoing history of seizures and they're being treated for it, I'd want to work with their neurologist to make sure that the neurologist was okay with that too. And then Overeaters Anonymous, has that been helpful? I think it really kind of depends on where somebody is going for those groups, and they're also their kind of own makeup for it. Some people I found it to be very, very helpful, and for some people they can find it a little bit difficult.
There's another question on bupropion, which it says Inderjeet Kaur is asking. She says she's curious because mostly bupropion is relatively would avoid it due to lowering the seizure threshold. So, any comments on this from your own personal experience?
So the limitation of bupropion within eating disorder populations is mainly for the restrictive and particularly for the purgers because they're shifting their electrolytes around so much. For somebody who has binge eating disorder who isn't shifting their electrolytes around, using bupropion is very appropriate and can be a very helpful medication because it helps with the dopamine too. And then there's the new medication that is the combination of bupropion and naltrexone. And using those together separately can be helpful. Particularly what I found with naltrexone is that it's really only helpful for those people that binge and become kind of euphoric on it. For those people who binge because they allow themselves to get too hungry or as a coping mechanism to kind of stuff down emotions, I haven't found it nearly as helpful.
That makes sense. Thanks for that. And does anybody else have any other questions? So you said that binge eating disorders is now the most prevalent of all the eating disorders. So is that do you see that in your own practice too? Is that what you see the most of?
So I don't at my level of care. I think insurance coverage of it is still really kind of tricky, but in terms of outpatient, that's where people are seeing the most of.
Okay. And do you find that people are screening enough for it?
No, I think asking those sorts of questions are really, really helpful because they put somewhere in the article the percentage of people with obesity who meet criteria for binge eating disorder, and their internal medicine doctors go about it in more of that behavioral prescribing a meal plan and prescribing medications instead of getting to the psychological components, which may be really helpful.
Okay. Well, good. Do you have any other, anything else that you want to add or any other take-home points for people? It sounds like this was a pretty, I haven't seen anything like this before, so I'm glad to have seen this.
The only other thing that I would like to say is that for the lisdexamfetamine, the studies look really good for it as long as you continue to take the medication. As soon as they stop taking the medication, people will go back into their same patterns if they haven't addressed kind of the underlying concerns.
Okay, good to know. And then there is one more question from Carrie Janik. Would you approve someone with binge eating disorder for gastric bypass, which it sounds you alluded to a little bit. She said, I never understood how anyone could be cleared if they have an eating disorder, or they all may have eating disorders.
Yeah, so for somebody who's actively engaging in binge eating, I wouldn't clear them until we could get the behaviors under control. The difficult part is a lot of times we can get the behaviors under control and the weight kind of still remains, and some people find the gastric bypass at that point in time to be really helpful. But along with that becomes kind of the switching of kind of addiction. So a lot of people who go from binge eating, who get that under control, get the gastric bypass, they're at much higher risk for alcoholism then.
That's good to remember too. So thank you. Well, thank you. On Wednesday, we're going to be, I believe, talking about anorexia nervosa. So stay tuned, guys. So the videos, as you all remember, they're on Psychiatry Network website, but they're also on the American Physician Institute website. And I've gotten a few I'm trying to respond back to emails as fast as possible, but if you have never signed up for the free CME through American Physician Institute, there is a link in this post above where you can click on it. Just make sure you're logged out and then click on that link and then sign up, like either create an account or sign in through your regular account if you already have one. And if you want to be added for our scheduling reminders for these journal clubs, we're going through mid-April every Monday and Wednesday, and I'm sending out emails once a week just reminding you guys of which videos we're doing. So just send me an email at psychiatrynetwork@gmail.com, and we will see you next time.
Thank you.
Thank you, Dr. Garber. We'll see you on Wednesday.
Absolutely.
Okay, bye.